field, as I understand, my understanding of the engineering and computer science world of this, there's a lot more sort of similarity when we talk about measurement, reliability and validity of measures and that sort of thing. So we'll spend a little time on that, but I think that they're more closely aligned than they are when we talk about outcomes, intervention, research. We're going to talk some about the value of randomized controlled trials and the strategies that we use to maximize positive results while minimizing the time it takes. I think you've heard throughout this conference and probably even before that there's a major disconnect between how long it takes to do research and how quickly we need to be able to get these applications out. So we're going to spend a little time there. And if there's only one take-home message, it's this third point for me, which is that there's a tendency in the field for us to believe that we build all this stuff and then we evaluate it, and that the research piece doesn't come in until it's pretty much sort of ready to go. And what I want to do is make sure we're thinking about the fact that we can infuse evidence-based work and the scientific method throughout the entire design, development, evaluation, and deployment process. And so at the end of that, we'll discuss a bit on how to evaluate while you're disseminating. It'd be really nice if we could all do randomized clinical trials, randomized control trials. We can't always do that. There are certainly cases in which a Ministry of Health, for instance, says, I need this application. I need it to run by, March of this year, and it needs to be out in the field. And we don't have time to actually do the sort of evaluation we'd like to do. But that doesn't mean we can't evaluate that work while we're disseminating it and while we're putting it out in the field. Okay. So let me start. Does that all sound like what people were expecting we were going to talk about today? Okay. All right. Good. If not, this is a good time to leave and go get an early lunch or something. But we're going to focus on a bit on the evaluation of sort of measurement properties and some of the details of that. And again, this is a primer, so I will apologize if things are simplistic in places, but I think it's worthwhile to make sure we're all on the same page. Obviously, something can be valid unless it's also first reliable, and there are some basic types of reliability, and I always try to remind people, especially of this sort of lower, let's see if this little pointer thing actually works. Well, no, it doesn't. It just goes back. Okay. This does. Okay. Remind people of sort of the target where something is highly reliable, but it's not valid. It's not hitting the mark. It's consistent, right? This is sort of like the way I throw darts after about 3 beers, right? So it's I'm consistent, but I'm releasing too high on a regular basis. That's a reliable but not valid measure. There's a few sort of basic types of reliability, especially in the mobile and sensor sort of technologies. One of the critical things we want to know about is the stability, the test-retest of it. Can you consistently replicate this outcome or replicate this data point? Whether it's two sensors closely situated on the same person so you can kind of replicate that way, or repeating of that measure close enough in time that you actually can get a reliable sort of precision on it. The one thing that's really critical about test-retest work is that you want to make your time frame between the two just long enough so that you don't have the sort of residual sort of effect or practice effect that's going on. So it's not like they just remember what they last did, or that there's still enough residual to it that there's enough independence of the two things you're measuring. But at the same time, not so far enough that the phenomena itself changes that you're trying to measure, right? So for something like measuring a sensor technology for measuring heart rate, you want to actually have an awfully sort of tight time frame because it's going to change pretty quickly over time. Other things like a personality trait, those types of things, you could actually have a fairly long sort of time frame if you needed to do that. One of the things that we do a lot in the mobile field, inter-rater or inter-device reliability. Can I get the same sort of outcome from doing multiple sort of devices? And then the type of reliability that most people talk about in the field but doesn't really apply but so much to the mobile space, which is mostly in the self-report interview or subjective sort of measures, which is it internally consistent? If I do a 10-item scale of depression, do all 10 of those items actually correlate with each other well, and do they all group together and appear to be measuring the same thing? So that's the internal consistency piece. Okay, and then, so we got precision, but precision's not enough, right? We also need accuracy. We need the validity side of the spectrum as well. So most of the time what we're looking for here is relationship to the gold standard or to the ground truth. That's the common terminology that you'll hear in engineering and computer science as well. We can do that easily through correlation, but correlation obviously isn't enough. My estimate might be perfectly correlated with the underlying ground truth, yet it might totally consistently overestimate or consistently underestimate sort of what the real ground truth is or what the real gold standard is. So that correlation is not enough in and of itself. People often will use agreement rates such as kappa coefficients, look at sensitivity and specificity, false positives and false negatives. And again, this is why I think sort of the connection between the sort of health sciences and the engineering and computer sciences actually overlaps quite a bit, because the health sciences folks stole this from the engineering people, by the way. Receiver operating curves and area under the curve to estimate sort of the relationship of true positives and false positive rates so that we can get as good of an estimate of accuracy relative to what ground truth is and what the underlying gold standard is. Okay. This is one of our problems with validity, though, right? A lot of times the things that we're trying to assess, we're trying to measure, are things that don't have a gold standard or don't have a ground truth that we can get our hands on. A lot of the things in the patient-reported outcome area fall into this category. Depression, pain, fatigue, important constructs, important to health, but constructs for which nobody can say, okay, I do have an externally valid, marker for fatigue that's going to give you that necessarily. So a few things that we have to then begin to think about when you're looking at validity in that context. To how the data that are obtained appear to be valid, do they seem to come from a source that makes sense to us? In the patient-reported outcome literature, that mostly means that as experts and other people look at the content of the data or the content of the questions, they are consistent with the construct they're trying to measure, whatever that happens to be. Does it behave like data from other measures of the same construct? So is this the concurrent validity sort of concept? I have other measures of heart rate or blood pressure or some other disease marker or a patient's fatigue or their depression, those sorts of things. Does it correlate well with those other measures of the same construct? And then finally, the one that probably is used not as much as it probably should be is construct validity, more broadly defined as, does the data that I get from the sensor technology or from the mobile technology that I'm employing, does the data look like and act like the underlying construct that I am looking at? Does it change over time the way I think the underlying construct is supposed to change? Does it behave in a similar pattern in a similar way? Is it higher? Is my fatigue measure much higher in chronic fatigue syndrome than it is in people with depression, than it is in the general population, et cetera, right? So there's ways that we can kind of test, does the measure and does the sensor technology that we're using, is it consistent with the underlying validity of the construct as we understand the construct? The other point to sort of make here is it's, I think, particularly important to involve the stakeholders who are going to actually use the technology in what validity is going to be most important to them, what they're going to look for. What's the question going to be when you roll it out and say, here's my new measure of X? What are they going to look for to say, okay, is that valid? What are they going to actually look for data there? And do that up front before you begin to do any sort of validation work on the things you're doing. Okay. Like I said, that was going to be short and brief because we're going to focus mostly on intervention outcomes. So let's start with the randomized control trial. We're going to start from the middle and kind of work our ways to the earlier stages and the later stages in the overall process. There are plenty of people who, and especially given the struggles that we have with randomized control trials and mobile technologies, will go, do we really have to do this? Right? I mean, is this really necessary? And in some cases, I would probably tell you it's not. Right? In cases in which you have a relatively benign intervention that's unlikely to cause much in the way of harm, there's hardly any, it's kind of minimal risk of the intervention itself, in which the cost and the opportunity costs are relatively low as well, there are probably some things short of a randomized control trial that could probably be sufficient. Right? However, if you're designing a mobile application or wireless application of some sort in which you think the FDA is going to have some purview in this process, they're going to expect a randomized control trial from you in all likelihood. There have been a few cases that I'm aware of in which the FDA has accepted data other than a randomized control trial, but there have been pretty slim, pretty few in nature. I will point you to the FDA's mobile medical application draft guidance that's out and available. And you can Google that pretty easily and find it online as well. The FDA is obviously sort of struggling with how they sort of think about this, and when does when does a device become a medical device, and when does an application become a medical application? That's some of their draft guidance to help you sort of understand and figure out whether what you're doing looks like it's the sort of thing that would be under the FDA's purview. But there are other reasons, even if you're not doing an FDA approved or you think you're going to need an FDA approval of some sort for the mobile application that you're developing. There are lots of other reasons for doing this. Almost all of our meta-analyses that are done in the field on intervention research focus on RCTs. And they focus on RCTs to the point that they cut off anything that's not, in most cases. So most of the times when we're doing practice-based guidelines, meta-analyses of various sort of projects, determining practice guidelines for anything that's out there, IOM reports as another example, often anything that's not a randomized control trial will end up on the cutting room floor. Okay. One of my, this is Robin Whitaker's, this is an example, Robin Whitaker's review of smoking cessation interventions and the effects of that. Now, our group was actually one of the first to do, actually the first to do a smoking cessation intervention via text messaging, but it was an open single-arm pilot trial. And so it ended up on the cutting room floor, appropriately so for a meta-analysis like this, where we're trying to find out, does it work better than a control condition? So keep in mind that for all the pilot work that we'd like to do and we need to do in the early stages of this, oftentimes if you really want to get it out into practice where the commodity that people look at is there a randomized control trial to do that? Okay, so let's talk about one of the problems that we have with this space. This is what we all know, how quickly the technology outpaces the research. So this is in 2005. Let's say you just published at the end of last year, okay? In 2005, you probably, and this is a fast time frame, 2005, you probably submitted a grant, and if you were really lucky, you got the award on the first pass at NIH. Probably not. You probably end up going longer than this, but let's assume you're really good and you wrote a really good application right off the bat. You're then going to have to do development and pilot testing of the application that you developed. That's going to probably take you 2 years, 18 months, somewhere in that ballpark, in all likelihood, again, if you're moving pretty quickly. Then you're going to need to recruit and randomize all the participants in your study. This is usually the thing that takes the longest amount of time. It's also the one that always gets us bothered at the NIH because it's the one that seems to go the longest and cause the most problems and cause the most delays in the intervention randomized control trial process. But it's going to take you some time to do that. Then, of course, you've got to do follow-up because these people, you've got to follow them for a year or 2 years or however long for your proximal outcome data point that you're looking for the primary outcome. And then if you're really fast and you have really good biostatisticians, you can crank these data out and you can get it published in a year or so. Again, probably faster than you would think. That's what you published in 2011. You missed the advent of the YouTube. You may have been actually prescient enough to know that in 2003, some kind of geeky guy from Harvard was developing this thing called Facebook, but you probably weren't aware of what that was even going to be about or how that was going to be used. You obviously missed the iPhone, you missed the Android, you missed the iPad, and you missed most of the other sensor technologies that have evolved and developed over those last few years to incorporate into your application. So the things that we publish now, the things being published in 2012, it's like looking back in time. It's almost like the astronomers looking back in light years, right? When we published in 2012, we're looking at stuff that was developed, at least in conceptually developed, back as far as almost a decade ago. Which is why if you look in the literature right now, most of what you'll see is text messaging interventions on mobile applications, right? Not because researchers are kind of like, excited about text messaging as the only sort of technology out there to do this work, but primarily because we're looking back 5, 10 years in terms of what people had available to them when they were developing the application before they did that. So we're going to talk some about how to speed that up. So let's talk about a few things that we can do early on, even if we're sort of wedded to the randomized control trial is the way we're going to do this. There's a number of ways that we can speed and bypass the development process. One, there are a number of existing applications out there. It's amazing to me how often we rebuild the wheel over and over and over again, even though there are existing technologies that will do most, if not all, of what we want to have done, but they just haven't been evaluated yet. There's, and I'll point you to Deborah Astor and Ida Sim and others in the Open mHealth initiative, but there's an increasing sort of awareness that we need to develop more open source and more modular software. We need to make the modules available, the software available for people to sort of pull, drop back in, and sort of build a more open source, which will also sort of speed up the development process for us. And obviously, the more component-based we can make this work, the easier it's going to be for us to share the development that we do. Right? So that a self-monitoring, why do we have to build 800 self-monitoring interventions for mobile phones? Can we build one, have some variants on that theme, but all kind of work from the same base as one example of that? So some things I think we could potentially do to sort of speed the development process as we go forward. We can also leverage mobile technologies for the research itself. There are things where the mobile technologies will allow us to actually be more efficient in the way we do the randomized control trial as well. And I think I have another slide, I'm not sure, but Pfizer right now has an FDA-approved trial that they call Remote for overactive bladder disease that's done totally remotely. Yes? Oh, it's closed. It's now done. Okay. Oh, is that right? Oh, isn't that interesting? Okay, so those of you who didn't hear, it closed due to lack of enrollment. So some of my points are not going to be particularly salient right now. But, so, and this is, some of the issues that we're going to have to deal with as we try to roll out some of these sort of newer technologies. But, these are, one of the things that, sort of is the concept behind this sense that we could do some of our recruitment actually online in a larger sort of sample of people. The tricky part for us is that sort of where these people come from, right? What registries do we pull from? What sources do we pull from? I will give you one good example of that from the smoking cessation literature. Rogers, in one of the first studies that they did in Australia for smoking cessation, they recruited from the mobile phone provider as opposed to recruiting in the typical ways we would recruit for some of those things. So there's some things that we potentially can do. It's going to require a great deal more sort of integration and partnership with mobile providers and those sorts of things to be able to do that work, but certainly doable. The other thing that's important is to recognize that most of what we do is the assessment is built into the application itself. So the things that we would normally consider our outcomes that would be treated separately from the intervention, and most mobile and wireless technology sort of based interventions, that assessment is ongoing throughout the time that the mobile application is being used, right? Most of us are building those assessment components in throughout. And so there's less of a need to have an independent outside assessment that goes on for the outcome. I'll also note that we can probably do some simple component trials that instead of building the entire thing and looking at an evaluation of all of it, that we build in components and we assess in components, and we'll talk about that a little bit more in a little bit later. And the thing that would probably actually, along with improving our recruitment, that would speed our RCT work more than anything else, is that we probably shorten our follow-ups. Now, I know this is sort of counter to the way researchers have typically thought, which is longer is better. The further out our follow-ups are, the more it shows sort of sustainability of the effect over time and those sorts of things. But because our technology is moving so quickly, there probably is a point at which we have to go, here's our proximate outcome that is important to us, that's as close to the time we need to do it as possible. Let's do it then, and then let's publish those results. If we subsequently have to do a second study for a longer-term follow-up, we can do that, but it helps us get our results out a little bit quicker. Okay. For all this work, and there's actually been quite a bit of discussion lately about John Ioannidis' study coming out that even with all this RCT work, a lot of our findings are end up being false over the course of time, are difficult to replicate. But even beyond that, even for a single randomized control trial, there's lots of failures that occur, many more failures than successes in the randomized control trial world. And these are just some of the things, and we'll talk about some of these for a few minutes. One of the things, this is just my list, failure to select the most appropriate outcome measure for the question, and we'll talk about that in a bit. Failure to select the most appropriate comparison condition for the question, to select the most appropriate sample to test the intervention, and the failure to develop a robust intervention that will maximize the effect size. I can't emphasize the last one enough. We see an awfully lot of weak interventions and then somehow amazingly think they're somehow going to make this major change in someone's life. So we'll talk about that as well as we do this. So, what appropriate outcome measure for the question? Make sure, I mean, these are some of the sort of course, sort of points, but that the measures that you're using are psychometrically sound, so all the reliability and validity things that we just previously discussed, make sure that the outcome measures you have meet that criteria. A single item self-report response is probably not going to do the trick as your primary outcome measure. It's not going to be reliable, it's not going to be precise or accurate enough. It needs to be sensitive to change, and this is often a problem that we see in the field, that people will use measures that were primarily designed for screening and diagnosis and use them as an outcome measure. Okay, so like the Audit C is a really excellent measure for screening alcohol problems in the field. Short, simple, 3 items. You know, you can get a fairly quick sort of screening of, does this person have an alcohol problem or difficulty? The problem used as an outcome measure is that it asks about questions of what you've done or what you've experienced over the last month. Right? So it's not going to change any more frequently than a month. At its absolute quickest. So you want things with relatively short reporting periods that have shown some sensitivity to change in the normal population. It measures what your intervention targets. Now this gets a little tricky, right? At the far end of the spectrum, we want outcomes of things like mortality and death and quality of life. But there are lots of things other than our intervention that contribute to mortality and death and quality of life at the far end of the spectrum, right? So you may actually have a desire to measure that as an outcome, but you want your outcome to be as closely affiliated with what it is that your intervention is targeting. If it's targeting weight control, measure weight. If it's targeting diet, measure diet. If it's targeting physical activity, don't measure weight as your outcome if it's physical activity that you're primarily interested in. You might want to measure weight as a secondary outcome. There's all kinds of other secondary outcomes you might want to consider. Your primary outcome should be as closely affiliated, as closely connected to the intervention and what its intervention targeting as you possibly can make it. And like I said before, if you can leverage the mobile and wireless features to embed that outcome in the system, because you're gathering intensive longitudinal data, if you can embed that outcome measure within the intervention that you're doing, that allows you to leverage a lot of data that most people don't have access to or availability to. Okay. The most appropriate comparison condition. If you think about this, what we'd really like to do is compare it to doing absolutely nothing, right? It gives us the best chance of finding an effect. Absolutely nothing at all. There's 2 problems with that. One is that in almost all cases, people are doing something even if you've assigned them to do nothing, right? They're doing something. It's not like, you know, it's not like people with diabetes are sitting around going, oh, I don't know what I'm going to do for, you know. They're still going to try to do something. There was a study, this is from decades ago, but a study looking at the placebo groups of people who are taking anti-anxiety meds, right? So in the placebo group, they should have actually no anxiolytics in their system. Yet approximately 40% of the placebo group had anxiolytics in their system, even though they weren't assigned Xanax or Ativan or whatever else they were supposed to be taking. So that's one of our problems, is that our control group isn't as clean as we would like for it to be in terms of having no intervention. And the other is clearly an ethical concern, especially the more and more with the field matures. The more in each of these areas, being able to offer someone nothing when they have a condition that there's already effective treatments out there for becomes an ethical dilemma for us. So the first 2 actually often aren't our first choices anymore for most things, unless there's a new condition that we know absolutely nothing about. Is it more effective than what we currently do is often the most common sort of question that we'll have. Based to usual and customary care, what people generally receive for this particular condition or for this preventive health issue that we're dealing with, does the mobile health intervention that we've developed, is it better than the usual care that's being delivered? A little more difficult as we go down the chain is it more effective than the same content delivered low tech? In which case you're now just controlling for the tech delivery aspects of this, right? This becomes a much more difficult thing, and in some cases that's going to be a difficult one to jump through, especially if the low tech one is more costly to deliver, and all you're really looking at is outcomes. You're probably not going to find an effect. So you have to kind of think about that. Does it, and these are all additive treatment designs as you begin to think about this as well, right? So does it increase the effectiveness over and above the standard treatment that's being delivered? So sometimes what you're developing is a mobile health application that's not being designed to be delivered as a standalone intervention. It's being designed to be an adjunct to an intervention that's already there, in which case you want to pair that standard intervention that's being used to that intervention plus the mobile health technology that you're adding to it. Again, the bar becomes much higher here, right? Part of why we have a hard time and we have so many failures in randomized controlled trials is because this is a high bar to set. It takes an awful lot of power to find a relatively sort of small effect size in this situation. And the last thing on the list is I want to point this out because a lot of times people have an outcome measure or comparison group that assesses for the idea that somehow what we're building is going to be better, it's going to produce a better outcome than what currently is available. When in reality, that's not what they built the application for. They didn't build it so that it would be produce a better outcome. They built it so it produced at least a comparable outcome to what we currently have and potentially do it at a lower cost, right? Or a more scalable way. If that's the case, then your outcome measure, I mean, you have to kind of think differently now, right? So that your focus needs to be on not necessarily am I producing a better outcome, but am I at least producing a comparable outcome, but more importantly to me, am I reducing cost? The other thing to keep in mind in this is that our traditional cost effectiveness analyses don't always work particularly well here, because typically what we do is compare during the study itself what was the cost to deliver this intervention versus what was the cost to deliver the other one, right, when we're doing sort of standard comparisons. Most of the costs of mobile technologies, mobile and wireless interventions, are upfront costs. They're fixed costs. They're not variable, right? So if we just look at it across the 50, 100, 200, 300 people in each arm of our study, we may not find a very big sort of cost effectiveness sort of bump. But if you think about, okay, well, if I now can scale this to 1,000 and 2,000, because most of the costs of a low-tech intervention are obviously much more variable costs and are going to increase with each person that's being that's using the project. Okay? All right. Selecting the most appropriate sample. Just a couple of things here. There's obviously always a tension in the field between internal and external validity. If you really want to maximize your effects, find the most homogeneous sample that you can test as possible, right? If we could find an analog in the human to the white albino rat, we would. Right? But we just can't do that. But if the closer, the more homogeneous they are, the more likelihood you're going to have a bigger effect. The problem is that now your data isn't generalizable to the real world, isn't generalizable to the typical sample of people who use this. So you want to kind of think through that process in terms of, how much risk do you want to take early versus later in a research process. Early on, you might want to take a much more homogeneous sample that you know is going to be most likely to benefit from the application that you're providing, and then gradually sort of expand that in subsequent trials if you need to. We always have a difficulty in the field with equivalent motivation to real world users, right? If you think about the typical research design that's being done, we actively recruit people, we pay them to be in the study, we badger them to death about follow-ups until they come in and they do all the things they're supposed to do, right? That's not the way someone's going to use our mobile app somewhere in the future. And the intervention is going to be something that they pay for instead, that they're going to use on their own without anybody following up with them along the way. The closer we can come, this is again a generalizability issue, but the closer we can come to the sort of sample that's likely to use this application in the future, the better off I think we'll be. And again, provide it to only those who will benefit. Now, I felt like when I was doing these slides, this was sort of, the slides for the intuitively obvious, right? I mean, but you would be amazed at the number of times we do interventions that at least part of the sample doesn't really need the intervention. The example I have at the bottom here is a classic one. Medication adherence is a critical problem in the field, right? Only about 50% of people adhere to their medications. I mean, that's kind of the truism across whatever disease entity and whatever treatment that they're supposed to be adhering to. Only about half of them actually adhere. The problem is that also means that half of the people are adhering, right, in a consistent way. If we do a study in which we do a medication adherence trial and we do it for all people that are coming in and getting hypertension meds, for instance, we've already sort of put a ceiling effect on the outcome because half of the people didn't need our intervention to begin with. Select the most appropriate sample that will benefit from the intervention you're providing. Okay. A few things about developing a robust intervention, something that's got some power to it that will have an impact. First, base the functional design that you develop on all that's known both theoretically and empirically about changing the outcome of interest. We tend to sort of make this stuff up, and even when we don't make it up, we only look back maybe a few years of research and data. Pull from as much as you can potentially pull from, both empirically what's been done in the past that seems to work for this particular problem, and also theoretically, how do we know how to change that behavior or change the sort of things that are necessary to change to make that happen. I can't emphasize enough how much more we need to do this than we typically do this in the field right now, to take the time up front just to really understand the problem, how it's been treated in the past, how it's been approached in the past, what are the mediators to change in that population, how does this actually happen, what are the mechanisms along the way. The more that we do, I think the better. I'm always amazed that people seem to have rediscovered, like for instance, reinforcement. And like I always feel like Skinner's turning over in his grave right now as he hears about all these people go, oh, if we reward people, they'll actually be more likely to engage in behavior. Duh. I mean, where did this come from? So look at the prior literature before we move on. I think it's really important, and we'll talk a little bit more about this when we talk about fractional designs. The computer programming field is very comfortable with doing modular object-oriented development, right? So that we develop specific modules and where they're self-contained and they basically sort of talk to each other. If we take those modular components and we associate them with the specific sort of components of the intervention as well, it allows us to more easily swap and move them around as we need to, especially in subsequent sort of upgrades, right? So if you have a self-monitoring component and you have a reward component and you have a, whatever else, sort of the various components of your intervention are, if they're attached to sort of specific sort of modules in the development process, then it allows you later on to be able to drop a module, add a module, do those kinds of things much more easily along the way. We clearly need qualitative feedback from stakeholders. I actually was just in a session before this for the substance abuse session that we had, and every one of those presenters actually did a very nice job of working with stakeholders, patients, providers early in the process to understand sort of what their needs are, how they use it, and that sort of thing. I will sort of just make a point, and we'll do a couple of slides as well. I think we can begin to sort of do more N-of-1 trials for iterative development processing, and we'll talk about that in a second, as well as optimization designs. There's some things we can do early in the process before we get to a randomized controlled trial. Because this is our problem, right? We have Pilot-itis. We do pilot after pilot after pilot. There's some nice things that pilots do, right? They answer a number of really important questions for us. Do the users actually use the application? So we can get sort of actual use data. And we can also get some post-hoc report on sort of how they use it and what they use it for. How they find the experience. Does it produce at least enough of a pre-post effect that it makes us think, okay, well, maybe it's time to now roll this out into a larger, more controlled trial. And then the feasibility of doing this. Can we pull it off? And it's both feasibility of the technical solution that we've developed. Does our technology actually work in this particular setting for this particular problem? And also feasibility of the study participants. Can we recruit these participants? Can they enroll? Will they do what we expect them to do in the study itself? Those are all important things. One of the things that's a problem, though, in most of the pilot work we do, if you think about a typical pilot, and I will confess that I have done my share of these, if not more than my share of these, is that we lock in our intervention for the 30 or 40 people, right? So we've developed this initial prototype. We now lock it. We can't change it. It's got to systematically stay the same now. We now do 30 or 40 people, and we assess them pre to post. And during that entire time, my programmers are sitting on their hands wondering what else to do unless I've given them something else to do that work on. And then at the end of all that, then we go, okay, well, now maybe we'll go to version 2. Right? There are ways to do this where we don't lock ourselves into that scenario. The one thing I want to stress for us is that I think there's ways, especially in the early development process, that we can do a lot more sort of smaller, agile N-of-1 designs. Build an initial prototype, run it with 4 or 5 people as almost sequential N-of-1s. then do the next version, and kind of, again, sort of more consistent with this iterative incremental sort of design process, that our early sort of data collection is also much more agile if we do it like this. Now, this is just an ABA design as one example, sort of the baseline period followed by the intervention period followed by the back to baseline period. There's a number of important things, but the thing that I was taught even way back in graduate school is very critical here is that you need a stable baseline, right? You want intensive longitudinal data of enough data points that you can go, okay, I've got a stable baseline, so now I've got something to build on to see if the intervention makes the bump, that makes the improvement. In the early days, the only way we had to do this was to sit and count. And I spent more than my share of time in graduate school counting the number of times that one kid punched another on the school playground, the number of times that a kid pulled the hair out of his head, the number of times that they, took their medication, all those sorts of things. I have a really funny story about pill counts, but I won't do that right now because I want to make sure I got enough time. One of the things that we have to have is that stable baseline period, and the difficulty has always been that that's been highly labor intensive and highly costly to be able to do. With our mobile technologies, and particularly with the sensor, more passive sensor technologies we have available to us now, we can get that intensive longitudinal data in a much more efficient way than we've ever been able to do before. So work that has in some ways sort of almost become dormant. People in the disability field still do a lot of single subject design work. But in the health services field, I think we could do a lot more of this stuff now that we have the capabilities to be able to do more intensive longitudinal data and collect data over time. This is just one example of some of that kind of work that we can do. I'll just point out that as well as that, there's the potential for us to even do better things with this intensive longitudinal data, that we can, again, borrow from our engineering colleagues, and we can do work in which we actually look at the control system itself and how these sort of things interplay among all the various sensors that we have available and all the data that's coming in. And then if we put in this intervention controller, this piece that we're now going to add, does that change the system itself? Just as some early testing sort of things that are potential down the road. Again, it requires an unbelievable amount of intensive longitudinal data to do, but it's potentially possible. The other thing that we can do along the way are, as we build these more robust interventions, is to really sort of test the components in a more systematic way than we currently do. If you look at most of the research we do, and particularly in the behavioral sciences, we tend to kind of go, okay, here are all the things that we think might be effective for someone. We'll throw all of that into our intervention, including the kitchen sink, and we'll see if that's effective, right? As opposed to being more thoughtful about which of these components should we use, in which combination, and in which order as we're making those interventions. So this is just a couple of examples. This is mostly Linda Collins' group at Penn State doing these sorts of designs. But there is the potential for us to sort of look at combinations using factorial sort of designs or fractional factorial designs. So again, also mostly borrowed from engineering. For us to be able to sort of look at what combination of components in our interventions seem to produce the biggest effect. The other thing is that if you think about most of the interventions we do in mobile, one of the things that's particularly nice about mobile technologies is their ability to be adaptive over time, right? That our intervention can change over time based on the results that we're getting. And so the example of that from the design world is SMART trials, sequential multiple assignment randomized trials, so that we can actually start somebody and put them in a couple of conditions randomly assigned based on their response, based on their outcome or some other measure. At some point in the future, we can then go, okay, so all their failures we're going to now put in this group, all our successes we're going to now put in this group, and we're going to do another randomization of the failures, for instance, and do whatever else we need to do there. But we can sequentially and adaptively look at our designs so that we can understand better how to sequence our interventions. If I've done this sort of prompting strategy for sedentary behavior as an example, and I've already prompted them 2 or 3 times, well, for what purpose do I need to continue to prompt them 2 or 3 more times over and over again, right? At some point I've got to adapt and I've got to do something different. Some of these designs will help us understand what's probably the best next thing to do in those situations. So I'll point you to some of her work as well, which I think is really nice. Okay. Evaluating while disseminating. So we've talked a bit already about sort of the early stage of this work, sort of the process of in development, how do we use research and the research methodology to sort of build something that we consider to be evidence-based even before we get to a randomized clinical trial, right? So at the end of that, you may actually be at a point where you're feeling pretty comfortable that what you have is a pretty reasonable sort of evidence-based sort of solution. You may or may not subsequently need to do a randomized control trial depending on your needs after that. If for some reason you have to skip a randomized control trial, the one thing that seems to drop off the face of the map more than anything else is the ability to evaluate while you're commercializing, while you're disseminating. So I want to spend a little time on those sorts of designs because they're out there and they're available, and I don't think we make enough use of them in the mobile technology space. Okay. This is also a design that's used quite a bit in single subjects designs as well. But interrupted time series design is an excellent way to sort of do this work where, again, you've got intensive longitudinal data of all the people that are in your intervention that you've provided. If you have built the intervention, the mobile wireless intervention, in such a way that you're gathering baseline data for a period of time before your intervention kicks in on it, then you have baseline data on everybody who's being able to use it, and then an intervention response. Now, you're not going to, as opposed to the earlier ABA design I showed you, you're not going to develop an intervention that you commercialize, then drops the intervention off at the other end so you can test it at the backside. Instead, what you can do is, and this is interrupted time series is used an awful lot by our finance world to sort of the trends of stock markets and that sort of thing. But if you think about this in the simplest terms, it's the concept that every one of these data points allows us to predict a subsequent data point, right? So if I have this kind of random walk of data going along in the baseline period, each one of those data points allows me to estimate with a certain degree of confidence around the typical confidence interval what the next data point is going to be, where it's going to be, how far up, how far down, right, and where it's going to go. Interrupted time series basically says, okay, well, so if you can estimate for me what the 10 points later out, what that point should be with a 95% confidence interval, and my intervention goes either below or above that confidence interval, I have a pretty good idea that it was probably the intervention that had an impact there. So that's the concept sort of behind doing an interrupted time series. Not controlled, still gives us some really nice data on whether there's been an impact. In this case, a couple things that will strengthen that, right? One is if you also then subsequently have a control group that you can kind of look at whether they also get that bump so that you make sure there's no cohort effect or something happening at the same time. And the other is if you can't do that, you have data, and in all likelihood this is the case in something that you're rolling out commercially, it's being naturally staggered, right? The person at day one who started in January, that's one data point for you, but there's a person who started in June, a person who started in September. All these are all staggered interrupted time series. And so if the result is from the intervention, then you'll get the bump at the intervention, but it won't be because of the time point that happened to be the case that's causing that effect to occur. So staggering these over time across multiple people or multiple groups is a nice way to do this. This, by the way, is a design that's used quite a bit in community-based interventions. It's used in hospital-based, school-based, right? I mean, the concept here is I can't randomize 300 schools, 150 to one and 150 to another. That's a little complicated to do. But what I can do is take a school or 2 or 3 schools, and I can do the intervention in the school system and just look at, you know, what has been happening in the school for the months and years before I started the intervention, and then what happens subsequently as a result. Another one, step wedge design. This was the kind of prototypic use of this was the Gambia hepatitis study. And this was, I think it's a nice example for us in the mobile and wireless technology space because oftentimes as we're developing, we're rolling out sequentially. We're not ready to roll out everything all at once, so we can roll it out in some cohort of people or, you know, some city first. And, you know, we're kind of building gradually as we're rolling things out. The step wedge design basically says I'm going to measure all of these people across all of these time periods, but the purple blocks are the ones where I'm only going to give the intervention at that time point. So the first group only gets it at time 2. The next group is staggered, so they don't get it until time 3 and then time 4 and time 5, right? So we can kind of roll these out in a gradual way and be able, again, to kind of get a better sense of whether the intervention that we're providing via this mobile or wireless technologies are being useful. And I won't spend a lot of time on regression discontinuity designs because most people tend to kind of fog over when I get into details. But suffice it to say, and there's a reference at the bottom here that I think is a really nice reference for sort of looking at these. It's probably the closest that we come to the robustness of a randomized controlled trial without doing a randomized controlled trial. And this is often the case. The time these designs are typically used is in a situation in which a Ministry of Health or a health system of some sort says, I can't roll this out with everybody. I only want to roll it out to my sickest patients, the most difficult patients. And, you know, so why don't we start there? And if you get that sort of scenario as you're going into a system, then this might be a possibility for what you would do, right? Because all you are doing here is continuously measuring everybody. Even though you're only going to give it to the sickest patients, we're going to measure everybody continuously from the lowest to the highest in terms of the problems that they're having. And what we're going to look for is what you see in the upper right, which is that in compared to the pretest measure and the outcome measure, there's a discontinuity in the regression line, right? So I've got this prediction that's going on during the control group, but then as soon as I get to the people who I'm treating because they're in the higher group, there's this bump that occurs where they're actually getting more improvement than they're getting from the others, okay? We don't want what's in the upper left. That's not a good sign. And then they've got a few other sort of examples of that. But that's the sort of thing that we're trying to look for here. So in situations in which you're being sort of constrained and they're saying, okay, yes, you can roll this out, but only in our sickest patients right now. This is a nice design for that sort of work. Okay. The other thing to keep in mind, and this is as we move forward, there are people in the field, obviously, who are talking about rapid learning systems. And the concept here is that in addition to or instead of randomized controlled trials in some situations, there's a lot of data that we can gather just from the normal process of tons of people going through our healthcare system, especially if we can collect data in a more systematic way across the board. And so this is IOM's workshop report on the learning healthcare system and our ability to sort of learn from it and be more agile in how we learn from it. And in reality, this methodology is very consistent with the way engineering world thinks, right? This is sort of the iterative process of kind of thinking through this stuff and seeing the effects over time and tweaking and changing and looking at whether that tweak or that change in the system actually produced some improvement in the outcomes that are being delivered. Being used more and more in some of the more managed healthcare systems, Kaiser, Geisinger, other groups like that, for some of the work that they're doing. But what I want you to think about from the perspective of mHealth is that we have our own little mini, for every intervention that we have our own little mini rapid healthcare learning system, right? If you're getting the data back to your server on all the people who are going through your intervention, you have data that's going on throughout that you can use in a similar way to the way it's being used in EHRs and a similar way it's being used in the healthcare system, to be able to make those tweaks and those adjustments and do the next version and sort of, okay, so let's look at that and see what its impact is. So just kind of think about that in terms of the way we kind of approach some of these efforts. The other thing I will note is that I don't think we make sufficient use, I'll go back to the randomized controlled trial, we don't make sufficient use of the fact that we could actually do automated randomized controlled trials as we roll out new versions. It's commonly done. We've done version 1 and it's out and people are using it commercially. And then version 2 comes along and okay, so version 1 no longer exists. Everybody who comes along now gets version 2. What if instead you were able to randomly, automatically assign, as people signed up to download your app or do whatever you had that you developed, if you could randomly assign those people to either get version 1 or your new version 2 and test that in an automated way over the course of the next 3 months or 6 months or however much time you want to do that, look at your data and determine whether version 2 is actually making an improvement. Right? So there are ways for us to sequentially and almost in a purely automated, fully automated fashion to be able to do randomized controlled trials within the context of the mobile health intervention we're delivering. Okay. Which is kind of what I was going to say, and I already said it when I get to the slide. So we talked a little bit about some of these and rolling it out into the automated systems, again, sort of thinking about N of ones as well. So that was sort of the point already before I made it before I got to the slide. So anyway, okay. I want to make sure we have plenty of time for questions about some things. There's some summary points I wanted to make here, though. one of the critical things, I think, is that the research method, the scientific method, those kinds of things should be considered throughout the entire process, right, from the initial concept all the way through to deployment. That we're constantly thinking about ways we can test these measures early on in the development process, throughout the randomized control trial when necessary, and even then subsequently when we're disseminating and commercializing. RCTs are always going to remain, I think, for many years to come, the gold standard of what we consider to be sort of the scientific evidence that something is effective and that something has worked. But I think there are ways that we can do that in a faster and better way, and that we can improve the process by which we do that, so we can do this more quickly. With the research designs that we can use that will optimize the intervention, and I don't think we spend enough time doing that sort of work where we spend a little bit more time in the early stages and make sure our intervention's optimized before we roll it out to an RCT. And there's plenty of cases that we could all probably look at in the literature that we would go, you know, if they could have done this instead of that, that would have probably been a little bit better. And then once again, I think there's some research designs that we can use, even if you have to, for some reason, sort of skip the RCT and you don't need it for some particular reason, you can still sort of do evaluation of what you're doing in an automated way as it's being commercialized and disseminated. So let me stop there and open it up for questions. Go ahead.
If you don't mind speaking a little bit more about retrospective control. We constantly run into clients like health plans or other provider groups who absolutely do not have the luxury of randomization, or even worse, they think about doing evaluation after the fact.
Right.
So then they look to us to maybe employ propensity score matching or something in that neighborhood, and then you get all the naysayers coming back saying, well, you can't control for the unobservable biases and what, self-deselection bias of all the people who opted out,
right.
et cetera, et cetera. If RCTs are the gold medal, would PSM even be a bronze? Would it even make the run?
Yes, so propensity scoring sort of stuff, and especially like you said for sort of retrospective sort of samples that you have as your control group. I think there's a number of things. I don't think people would say that's sort of the gold standard. Like you said, it would certainly be a close second. My concern with the field is that we have a tendency to set the gold standard for everything. Right? It's easy for us, and this is what we have with reviewers, whether they're publication reviewers or whether they're grant reviewers. It's easy to nitpick every design anybody has ever produced, right? And they're set sort of critiques, right, for the propensity scoring and retrospective control sample. And there's things we can do, just like you said, is closely match our control sample, even if it's retrospective, to the sample that we're using in the intervention study. And we can nitpick that to death, and like I said, they're pretty standard sort of critiques that people could use for that. But then, I mean, at some point we have to think about for what purpose, right? I mean, why are we doing this work? I mean, we originally developed RCTs to make sure we weren't harming, at the very minimum. Major harms we can detect fairly easily, right? I mean, we stop studies immediately because of major harms. The minor ones, if we can kind of collect those and pick those up if we measure them fairly well. And especially in situations where interventions have sort of minimal harm anyway, we've already sort of done some pre-testing to know that the harm's pretty minimal. The opportunity costs of what people would do if they didn't do our intervention are relatively low. In those situations, it should be perfectly acceptable. Again, this is not the NIH speaking, this is Bill Riley speaking, but it should be perfectly acceptable that that's a standard that we can live with, and that's a standard that we can say, okay, there's more than sufficient evidence. I'm always afraid in the field, this is a longer answer to a short question, but I'm always afraid in the field that we set the standard so high that people don't do the, quote, lesser sort of evaluations and assessments that could be done. And I think that's, I mean, especially in some situations where you don't have the option, the opportunity to do it, that's perfectly acceptable as a way to sort of assess this. So, other questions? Oh, good. Okay. Thank you. Yes. Here you go.
So I have a question about randomized controlled trials. What I'm trying to understand from what you were saying, that you could do sequential randomized trials within one, so that if you have an intervention and you want it to evolve, So you kind of have phase 2, and then within that, you can compare the two to each other. And I'm just, maybe I don't understand it, but I'm concerned about power. Because how can you then compare within, if you have just barely enough power to get your study done, if you're comparing a control group to an experimental, then if you introduce another experimental condition that is not all that different from your first,
Right.
how do you actually measure an effect?
Yeah, so, and it's a common question, and when people talk about these sequential multiple assignments or randomized trials, typically they power for the primary outcome, right, for that first assignment that's been done. And so, yes, you are, in many cases, sort of underpowered for that sort of second effect that you're trying to get when you do sort of the subsequent randomization. So you are underpowered for that. I think most people would argue that it's still sort of a beneficial sort of thing to do at that point, that, even if you now think about those next steps along the way as sort of more exploratory and hypothesis generating as opposed to hypothesis testing in nature, that you're still actually sort of getting some benefit from doing that second sort of prong along the way. But most people wouldn't try to power for like the end of that sequential trial. They would power just for that initial random assignment.
But so then is it still appropriate to change your intervention somewhat and compare it to your control group? Or is that not considered scientific enough when you're not comparing the same static little thing to
Yeah. Well, you're one, only going to make your assessment, your primary assessment at the point before you did that second randomization, right? So that kind of takes care of that one particular issue. There are people who will talk about the fact that, even if you've done this sort of subsequent line and you find no effect, no difference in those two groups on that sort of sequential next step, you could then subsequently collapse those. Now, people would argue, again, they can nitpick that to death, but the bottom line is that if you really don't have a difference between the two groups, you could potentially collapse them at that point. So, yeah. We're getting into the weeds, but that's good. Other questions? You want to hear the pill count story real quick before I let you go? So in graduate school, for my first year at grad school, I was helping one of the people on their dissertation, and it was on medication adherence and mostly physician-patient interactions. And so I spent actually most of my time listening to audio tapes of doctors and patients talking to each other and coding the heck out of that for long periods of time. But my other job was we were pill counting, so my job was to kind of hang out at the primary care clinic. And as people came in, they were supposed to bring their pills, and I was supposed to count how many they still had left in their pill case, just to get a sense of sort of how many pills they'd actually used over the course of the time from the last visit. So I was there working late one night in the primary care office, and I had been thank you, counting pills. See, I'm already coming back to how tired I was at the end of the day doing this. And so everybody had pretty much gone home, and the janitor was cleaning up. And this is, of course, you have to think back this is how long it's been since I've been in graduate school. In the waiting room office were those old cylinders with the sand in them for the smoking, so when you smoked in there, you could put your cigarette out in the thing. That was back when you could smoke in a doctor's office. And the janitor came to me because he had seen me counting all these pills, and he said, "Did you want these?" And he had he must have had 100 of all varieties of pills that people had buried in the sand in the smoking thing because they knew I was counting pills, and they didn't want to look like they hadn't been compliant with their medication, so they buried all of them. So we have to kind of think about all the various ways that people can sort of trick our technology, even from the low-tech all the way up to the high-tech end of it. On that, I'll just say, we can stop early. I want to thank you all very much for your time and attention. So, talk to you later.